Yeah, so I would just start this way. If you guys don't finish your residency of your training and you guys are not good doing laterals, I mean, you're way behind. 10 years ago, 15 years ago, when we used to come in here, Dr. Pimenta, we used to, present lateral, and people were like, "You're crazy, it should be malpractice." Dr. Pimenta probably remember L4, L5 lateral. Oh my God. Remember, Dr. Pimenta? I mean, it was like they said they should be a malpractice.
I'm used to being crazy.
and the real story is that it's an amazing procedure. Once you do these things right, and you know the ins and outs of the lateral approaches to the spine, it will change your life as a spine surgeon. And I feel so bad for the surgeons that are limited, that they only do T-leaf, A-leaves, lateral, posterior lateral fusions, and when they see lateral, they're like, well, I don't think it's safe. I can tell you guys, this is the way. And I'm gonna try to show you a little bit, like a little primer, how is it? And we have one of our fellows in here. The thing is that if you really want to have a good outcomes on this surgery, you need to have a really good and intense preparation. This is a surgery that has a very little room, and if you stay there, the outcomes are amazing. But if you get a little bit off, you're done. It's different than T-leaf. For example, T-leaf, there is 1,000 ways to do it. You put your retractor, you get on the disc space. You can leave the retractor 3 hours on there and scrape the disc, make holes in here and there. Patient wake up, not necessarily bad. The problem is you end up, as you know, putting a little cage. You have risk of CSF leak, all these things, something that never happened with the lateral. But if the lateral, you get a little bit, let's say you leave the retractor for 1 hour there, I bet you the patient is gonna wake up with a full femoral nerve injury, Or if you lose a little bit your anterior orientation, you're gonna hit one of the big reds or one of the big glue and game over, yeah? Guy's gonna bleed 4 or 5 liters of blood. Or if during the approach, you're not careful and you don't move the retroperitoneum the way that should be, then you have a colon injury. And if you're in a really bad luck, this patient is gonna be septic in 24 hours, gonna die. So that's what I'm telling you. This thing is not to scare you, but just telling you, I always like to compare two cars. This is like driving a Ferrari or a Porsche, If you know where you're driving, that's an amazing machine. But if you know how to drive a Ferrari or a Porsche, good luck, my friend. The first curve, you're done, And then because we're so arrogant as surgeons, we blame on the Ferrari and the Porsche, oh, these bad cars, So that's what we do as surgeons. Oh, it's about system. Oh, it's just, At the end, is in Colombia we always say every bad worker blame on the tools. When you're a good one, it's you're the one who has to get better. So anyway, it's a little bit of introduction primer, but I can tell you, once you do this right, you guys are gonna love it. You're gonna spend more time with your wife, you're gonna spend more time doing your hobbies, you're gonna spend more time doing more things, and I'm gonna show you when we do a demonstration I'm gonna do just a straightforward lateral approach, like standalone. Skin to skin, I promise you. I'm not gonna take any shortcuts. You do it in way less than half an hour. This is amazing. And the patient go home the same day. And if you guys don't believe me, you can ask Dr. Pimenta, or you can ask the fellow he just started with us that I'm trying to indoctrinate him a little bit. Where is Jean? He's here, Will the patient go home next day? Go home same day, standalones? Here you go, see? So I'm not lying, we have a good witness. So I think it's amazing. So I'm gonna give you a little bit of tour what's happening with the lateral world and how is it, okay? So I'm so grateful because everything that I know about lateral, I owe you pretty much to Dr. Pimenta. Dr. Pimenta, Dr. Taylor, these people put together the procedure, and I just ride along with them, and I learn from them, and we push, and we would critique each other, and then the procedure is what is right now. First thing that you have to understand, this procedure works very awkward. Why? Because it's a concept that no one of us has been trained on. You decompress the spine without doing any bone work. No laminectomies, no facetectomies, no nothing. So it's hard for you to believe that how come just by increasing the disc height, actually you're opening the foramens and the central canal. And we always fight this thing all the time. People say no, but because we're doing it for 10, 15 years, and for example, I do MRI post-op on every patient that I do, you can tell getting the right patient with the right indication is amazing how much they're open. So that's the first challenge with the lateral approach. The second one is, okay, so it works as indirect decompression. One big advantage is that you don't deal with the posterior band. You don't take the interspinal ligaments, you don't take the facet ligaments. All those things are intact, which is amazing because the spine is a very stabilizing procedure. Have you seen a T-leaf that can be done standalone or without screws and rods? Doesn't exist. Because the first thing that you do with a T-leaf is destabilize the spine. You, boom, blow out the facets, take the parts out, trying to get in Cambridge triangle. When you go lateral, you just open a little window on the annulus, take the disc out, in and out, and then at the end, ALL is intact, PLL is intact, interspinal ligament intact, everything else. That's why you can do it standalone. Yeah? Okay, second, this is amazing. Believe it or not, standard surgeons, they say they don't care, but let me tell you, a CSF leak can be a nightmare, If you have a CSF leak and the patient ends up with arachnoiditis, game over, That's the classic patient that showed, I'm sure that you guys see it in your practices, in your residencies. Patient come to the clinic with post-op of any open approach, CSF leak, burning pain. Good luck, my friends. That patient will be with you forever. He will end up with any spinal cord stimulator, you name it, anything in the world, nothing will make it better. And why that happen? You had the CSF leak, little blood came into there, clustered the nerves, get a big arachnoiditis, you're done, And then not to mention, patients that end up with the lumboperitoneal shunts and you name it, yeah? So it's not good to have CSF leaks. When you go lateral, I promise you will never have a CSF leak. And if you have a CSF leak on lateral, you're an animal. I don't know how you get there, yeah? So that's another big advantage of this. Again, the other one also is a very physiologic procedure, because you get at this space that has been collapsed, and you're just trying to restore and give the lordosis that the patient is going to give you, Obviously, you want to start giving more lordosis. You can go then and do additional things, which are cutting the ALL, the ACR procedure, and putting a hyperlordotic cage, or going from the back and do like a Pontes osteotomies, any type of osteotomies, and give some lordosis. But that's like a extended approaches lateral, yeah? So I'm going to tell you the story, which I like to show this one a lot because the older you get, the more you understand and you credit to the people who paved the road for us. So this is what I learned from Dr. Pimenta in terms of the history of the lateral and Dr. Taylor and all these guys. So correct me if I'm wrong, Dr. Pimenta. So in the late 90s, they start doing this thoracoscopic access, to the spine, correct? And if I'm not wrong, you were trying to learn how to do that, yeah? And you were still working in Brazil, and he decided to learn. And at that time, there is an Argentinian neurosurgeon that has been living all his life in Germany. And because Dr. Pimenta, actually, were born in Germany, or you grew up in Germany? What was that?
I went to learn thoracoscopic surgery, and Rosenthal, the guy that you described, the Argentinian German guy, convinced me to stop doing brain work because I got in love with endoscopes. And I thought that endoscopy would be the next thing in spine. I said, I will develop everything endoscopic to the spine. So the only one that really worked was not endoscopic, was a lateral approach. But so this is an evolution of what we did this.
Yeah.
So it took me 8 years to convince you to do lateral.
So listen, Kai and Charlie, I can do this from the fast mode of the nice story mode. You want me to go fast or tell the whole story? You guys tell me, because I can go fast and knock down this thing in 10 minutes or get like 20 minutes and be more like telling stories and move. Story. Okay, so let's keep going with the story, okay? So that's the Pimenta. He went to Germany, look at Dr. Rosenthal, and in the meantime, the Americans in here, there were 3 big forces doing endoscopy. Dr. Reagan, that I'm not sure if Reagan is still practicing, I think it's in Texas or something.
Yeah, he was in Texas back at that time with Paul McAfee, and they described the trans-psoas laparoscopic work with BAK cages, but they stopped doing because they had 20% of dysesthesias.
Exactly. So the Americans went doing that. So, well, McAfee, Reagan, and then Digman, he was at BNI at that time as well. They were like the big endoscopic forces in the 90s, and it was a big echo endoscopy. And then this is the first question for you. You guys are going to ask me, why are we not doing that much endoscopy today? And then that's not part of this talk, but very interesting, Endoscopy has been since the 90s. Why is not as advanced? It's been for more than 20 years, What is holding the endoscopy to be exploding? So anyway, so after that, Pimenta, correct me if I'm wrong, he went back to Brazil, and because Brazil's situation, endoscopy, and then he wanted to put real cages, do a real job. So what he did is he incorporate all the, I would say, mini-open, expandable retractors access with what he learned with endoscopy, and created basically the lateral retroperitoneal trans-psoas approach, So basically, this is the story real. You have a guy here still alive that actually described, I would say, probably the biggest improvement in spine surgery in the last 15 years. If you ask me what is the biggest improvement in spine surgery in the last 15, 20 years, I will say is this: pedicle screws, lateral approach to the spine, kyphoplasty, and BMP. I don't think nothing else revolutionized more the spine surgery. So there you go. So we have Pimenta in here, and feel free to interrupt me anything when I'm going in here, but this is a big deal, because when he did this lateral retroperitoneal approach, he just now was forcing a cage on the spine, but he was opening the window to a brand new approach and options to the spine. And if you look today, we go thoracic, lumbar, everywhere, and now the approach is not lateral, it's also prone. It's like, this is like he opened the window for a brand new world. In other words, let's say on the cars, I like cars a lot, so I like to compare. He basically bring the electric cars on the field. First was a little roadster, now it's trucks, this and that, so the same thing. So he put into the industry one big access to the spine that actually works amazing. So, and then the story keep going. So as always in most of the parts of the world, when the Americans see that something that works, they grab it, they put it at the best, they marketing, and they dominate the world. So that's what's happened with Pimenta approach. Americans went to Brazil, look at his approach, they saw some potential. They say, you know what? We like it, Dr. Pimenta. Can we find some monitoring? Because we understand there is some nerves that we have to negotiate there. Can we make it better? And then do the American marketing thing. And there you go. So the approach was created. They incorporated the monitoring. They improved the retractors. And this is kind of a little bit the way that the retractor is, the procedure is. You go from the side. You go to the retroperitoneum, get into the psoas. Once you get through the psoas, you need to find out what is the main complication of the procedure, that is lumbar plexus injuries, find out what is the femoral nerve, trying to retract it the way that you like it, and then get in and out as fast, put your graft and do it, yeah? So that's basically the entire procedure. And in the way, you have a couple of hurdles to go through that you have to negotiate. First one is, once you open the skin and the muscles, the abdominal wall paresis. 2-3 nerves that are there that can give you the pseudo hernias. Once you get into the peritoneum, make sure that you don't make a hole in the colon. Once you get through the psoas, make sure that you respect the lumbar plexus good, you move it the way that you want it, and then don't fall anterior, injure vessels of ureters, whatever is on the front. As long as you stay in that corridor, it's an amazing procedure, yeah? First paper that got published on the American Literature Peer Review, Bill Taylor, Luis Pimenta, 2006. Amazing, yeah? It took 6-7 years to actually end up with the very first paper on the regular literature. And after that, it's like, I don't know, it's like 1,000 papers right now on lateral. It's like everywhere, This procedure has been so much scrutinized that there is everything on lateral right now. There was the society, which was very important because all the people who was doing lateral at that time, 20, 30, 40 surgeons get together, discuss what were the challenges, and end up with solutions. And they did a meeting, and then a lot of things happened. And I would say this Solar Society actually accelerate a lot the adoption of the lateral. And then there was the validation, which I was lucky that I came a little bit, not too early, but in the middle of the road, this procedure, and I was able to question a lot of things that were happening, and we go deep, and we were able to validate a lot of things and helping what the procedure is today. And one of the good things is this one. For example, I also, when I started doing the surgeries, I wanted to know what we were facing, and after dissecting some cadavers and trying to replicate the surgery, we found that actually the whole game is how can you get in the spine, this is the femoral nerve in here in the plexus, in the lumbar plexus. How can you get in front of the femoral nerve, retracted from the front to the back, in and out, do your job, leave a cage, and get out with no complications. So it's basically the entire game. So, and then I'm going to show you the difference between T-leaf and lateral axis. When you're doing a T-leaf, it's on the right, you're dealing with the exiting route and the traversing route. You find the Campbell's triangle, and you force a little cage in here through, 1.5 centimeter space. Worst case scenario with a T-leaf, maybe a foot drop, if you really bang this route so bad. But which is very interesting is when you're doing lateral, if I get it in 4-5 and I retract the femoral nerve, when you have the deficit and the complication, it's so nosy and it's so much clinical significant. Obviously you cannot extend your knee, the full femoral nerve. It's because if you look in here, the injury that you create is a true peripheral nerve injury. So basically in here, most of the time the injury is preganglional. So you're not really out as a peripheral nerve injury. So when I hit the femoral nerve in here, then it's like I'm doing a T-leaf on L2, L3, L3, L4, and L4, L5, and at each level, I'm banging the exiting root and damaging. So that's why it's so critical, the lateral, when you expose it, because the injury is totally different than the retraction on the T-leaf. And that's why you have to be very careful how you move this nerve and very efficient. So it's a totally different procedure, yeah? And as you see here, looking at this little picture, this is actually where you go. So it's different stages as you go on the approach, and how can you put your retractor right here in front of the plexus, move it from the front to the back, because these nerves, they like to be retracted if they like to be retracted from anterior to posterior. They don't want to go this way. And then once you retract it, is how can I just do it for very little? The best example is this. Put my finger in my eye. If I keep it for 10 seconds, I'm okay, I can see. I put it for 1 hour, I'm blind, yeah? So the injury is not you hitting the nerve with the cup or with the knife. The injury is the retraction for too long, getting all the ischemia, losing all the myelin, and if you keep going more, you have axonotomesis or neurotomesis, yeah? So your game is, how can I get there? Worst case scenario is a neuropraxia that I know that in 6 weeks is gonna be totally better, And when you guys been doing these lateral cases, you know how the patients wake up. And how many of you guys are doing laterals in your programs? Okay, normally it's around 10%, it's getting a little bit better, yeah? Is not the number, Dr. Pimenta, 10%? Yeah.
Isn't crazy?
It's amazing after many years, and it's such a great procedure.
Crazy? I don't think I'm so crazy.
Yeah,
it's
I like
crazy
it.
that the adoption is so low.
It's crazy, and to be honest, I think it's a generational thing, Dr. Pimenta. We need to keep creating the fellows, and the fellows going through academics and start from scratch, the resident from zero, But which is interesting is why 10% adoption only? I can tell you why. It's because if you don't start these things since you are a junior resident, you don't want to get the learning curve when you're not attending, because you're going to injure a lot of people in your way out. So it has to be a very progressive thing. But I can tell you, if you, for example, spend with any of us, Dr. Pimenta or lateral guys in here, in 3 months, I promise you, you get perfect for that. You just need to be coached good, understand the technique. It's an amazing surgery. It's so simple at the end. And you just need to be in a standardized same way every time to get your good results. So what are the indications? The indications are watching here, basically everything that happened on the spine, from degen cases to deformity, getting into trauma and tumors. So whatever happened on the spine, you can tackle from the lateral side, And so I'm going to show you a couple of detail, a little example later on. So this is basically where we can go transthoracic, thoracolumbar, lumbar L2 to L5, and nowadays, they're doing A-lifts with the patient in lateral position, which is not transthoracic that, but you do an A-lift on lateral position, And some people like it. This is the classic way. Best indication in degen cases is spondylolisthesis. It's like every time you see a spondylolisthesis, not even think to do a laminectomy, you go lateral. Just by increasing the disc height and moving the vertebra back, getting the anatomical reduction, everybody gets something like this. You see here? That's the norm. You decompress, you move it back, everything open. It's an amazing results. Okay, so there is a lot of things in this. In the industry, you will see a million of different retractors, 2 blades, 3 blades, 4 blades. The colors comes in every color, every axis. Every sales guy is going to give you the pitch why his retractor is better than the other one. I wish that the retractor made the surgery, It's a combination of everything, It's like, again, you're buying a car, and the guy just put a lot of emphasis on the freaking airbags. I wish that the airbags is what make the car fine. No, it's fine, it's one more thing, but how is the engine, how is the suspension, how is the, all these things, yeah? But it's important, you have to have every good piece, That's what I always say, this is like a Ferrari or something like that. They put the best pieces, the best materials in one single product, and then they let it perform, So the question is, you have to answer yourself. Do I want to keep driving regular point A to B cars? Or I want to really go into high performance, do a thing, roll like a champ. We as spine surgeons, neurosurgeons, orthopedic guys, we are on the top, If we were mediocre guys, we were getting into another field. We want the best. We want to perform the best. Basically, we were golfers. All of us, we are playing on the PGA every weekend. We're not on the Corn Ferry Tour or something amateur. We play, because that's what happened to us, Once you guys graduated, we don't have minor leagues and that. You just right away, you go into the NFL, So you guys have to perform at that level. And that's the big thing. That's what I like to mark this course, because you guys are 1 or 2 years to be playing on the PGA, NFL, on the MLB, on NBA. There is no minor leagues for you guys. So you guys have to put yourself in the best position so you can perform like Pimenta, like Charlie, like Kai, like all of us, So cages, oh my God, like a million cages. See here, this is actually one company only. If you go to another company, it's like a million shaped files. But why is this? Because this surgery is very critical, so we want a specialty cage for every little thing, And you use 90% of the time similar cage, but you learn that for some applications you need this specific one, so you make it work, Complications, watch this. This is all my cases. I'm not hiding anything. I've been having almost every complication in the land that you can know in lateral aspects, in a lateral axis. And actually, we create new complications. For example, this one, this is something that we created new, yeah? Like a coronal fractures of the spine, And it's very interesting. When we start doing lateral, I remember I was getting trained, first thing that comes to your mind, even now, is like, how I'm going to leave a cage alone without putting a plate? We were putting plates on everybody, correct, Pimenta? And then we find out that we start having these coronal fractures. And how the thing happened? This is actually very simple. You put a big cage in here, and then there is a little straight riser. If I put a screw in here, between the screw and the end plate, between the screw and the end plate, you create this little stress riser that break it up. So the surgeon comes like, oh no, I had to put a plate, this cage is gonna move. Actually, you're putting yourself in a situation that make it worse. If you ask me when was the last time that I used a plate, I can tell you years ago. I only use it when I cut the anterior longitudinal ligament, because if I don't hold the cage with something, the cage goes up. And actually, I use cages that has ears, like a standalone, so that way the cage doesn't move anterior. But after that, I don't use any plates. The problem is, this is something that we talk to the residents. We are forced by the RBU world of that thing. If you put a plate, you have one more code. You can make more money. So please don't be so cheesy, That code doesn't give you too much money, And you will pay on the back you get something like this, So plates are very limited applications. When your attending comes and say, oh, no, you have to put a plate because the case moves. Listen, you're not doing the procedure right. Make sure that you pass the midline. As long as you cross the midline, that case is not going to go to that side. Correct, Pimenta? Please say something, my friend.
Go ahead.
Is not the way?
Correct. I would stop you when he's wrong.
Okay, perfect. So that's good. And then you see more complications, abdominal pseudo hernias, you see here? So you get from the side, you want to be very aggressive, you open a big incision like the general surgeons, they give you everything, they just put their head, move everything out, But the problem is getting into the abdominal muscles, you have these 2-3 nerves, ilioinguinal, iliohypogastric. And if that nerve, you don't dissect it and move it around, you have that complication. And, it's not unusual, especially females, they come very mad at you. Dr. Uribe, I'm doing great, back pain is nice, but what is this thing, it's bulging here. And they go to the primary care, they send it to the general surgeons, and they don't find the real incisional hernia, just abdominal pseudo hernias. And that thing happens just at the beginning because you're not careful enough dissecting the muscles with, like a little clamps instead of going and cutting with the bobby through and through into retroperitoneum. And then, we can go and go. You see here thoracic one, a big hemothorax. You see here plates. Again, see, you use plates, then plates going out. You don't want to babysit in a plate. So please, guys, don't only use plate when you really get forced. Don't listen to these industry guys trying to push one more widget on there, So only use it when you need it, yeah? And then I'm going to go over very important things. Probably this is the most important thing that I learned on the last, 10 years doing lateral access to the spine. We were trying to find out, what monitoring was more important, if it's adding MEPs or of the putting, like a all-time monitoring on the posterior blades of the retractor, trying to see if that one helps to monitorize what we call nerve health state. And what we found, actually, the patients that end up with full femoral nerve injury on this group of patients, actually there was one common denominator, which was time of retraction. So time is so critical. And then it was in common, when you retract more than half an hour, the femoral nerve, it's good chances that you will have some issues. So time is very important. So when you do lateral transpsoas, these are the 3 things that you have to control. If you control these 3 variants, I promise you, procedure is going to be great. One is the direction of the retraction. Make sure that you retract the nerve from anterior to posterior. Second, time, again, less than 20, 30-minute retraction. And the third one, amount of retraction, For you, it's great. You open the retractor like this and you see everything, But the problem is you're going to put a case that is actually the size, this end plate with this one. Why you want this plate around here and here? Then you're going to be dealing with the segmentary vessels, you're going to retract in more the psoas, more tight pain, a lot of things. So these are the 3 variables that you have to control. And then I'm just going to finish after these 2 more slides. The lateral, what are the variants? And the variants are, the regular transpsoas, or you go in front of the psoas. So the question is, all you guys have been listening about the O-leaf, and we go pre-psoas and all these things. I'm going to tell you why the pre-psoas exist, okay? So these are the axes. Transpsoas, you can go MIS to a small incision with your finger. You can go mini-open. There is like a million marketing names, shallow docking, direct view, whatever. But it's basically you go mini-open, look through the fat, find the muscle, dissecting, make sure there is no nerves, and then hopefully you're in the front of the plexus, And then the pre-psoas approaches, which is going in front of the psoas, and you have to be careful with this one also. I'm going to show you a little bit of data, but when you go pre-psoas, it's not like you don't have complications. And they come to you and they say, you don't need monitoring, it's amazing, everything was good, but it's very interesting because the papers that are well published show actually the pre-psoas approaches has a lot of femoral nerve injuries as well. They don't come for free. And you start dealing with vessels and a structure that you don't deal with when you go transpsoas. So basically, choose your poison. Or you want to deal with vessels and ureters and once in a while have a femoral nerve injury, or you want to deal only with nerves, and worst case scenario is a femoral nerve injury. Once in a while, if you're an animal, get a vascular injury, yeah? So position, the other variants, as you get from Dr. Pimenta. So now lateral is not anymore lateral, it's also in prone position, yeah? Again, choose your poison, you know. Prone has a really good advantages, you know, Dr. Pimenta mentioned the lordosis. You can access at the same time the posterior column. Is a very good and friendly with navigation systems, but lateral makes shorter the access. The problem is I'm biased because I'm doing thousands of laterals and less than hundreds of prones. But I would say one is not taking the other one. They complement each other. So then when you do pre-psoas approaches, you have to be careful, yeah? So why the pre-psoas exist is basically because a lot of people were trying to do transpsoas approach. They were having a lot of nerve injuries. They didn't have a good way to find the nerves. What they did is they migrated anterior in front of the psoas, trying to move the muscle out. But the real truth is that it doesn't come without problems. That's why also the pre-psoas approaches are not everywhere, you know, because the complications happen. And what are the challenges with the pre-psoas approach? These three. If on the transpsoas, you have to control time, amount, and direction. In the pre-psoas, you have to control orientation, which is awkward, because you're working oblique, trying to put a cage actually lateral, so you have to adjust your mind a lot, or unless you have a really good navigation system that doesn't give you anything. Vessels are always in your way, so you have to make sure that the vessels are your big enemy here. Same thing like other structures. And then also, having a good end plate coverage, diaphysis to diaphysis, can be challenges oblique, because you're afraid that you can hit the nerves in this corner when you go oblique. So you want to go one diaphysis to the other one. It's very important to go a true lateral. And why so important? Because you don't want subsidence. Subsidence is a big enemy on the lateral surgeons. You go to the surgery, you put a cage, it looks great, but if you damage the end place or you're not really sitting on the diaphysis, in 6 weeks, this guy come back to the clinic miserable. Back pain again, leg pain again, and you see the big subsidence. So these are the shortcomings, okay? Transpsoas, you deal more with the nerves. Pre-psoas, you deal more with the vessels and the structures. And this is a really good drawing that our illustrator in our institute, Peter Lawrence, did it, which I guess sometimes so annoying because people show it, never give credit to him. He put a lot of time doing this. And I think it's very descriptive. You see here, what are you facing, where you can go, and what are the chances. And then just to finish, I don't want to get more far, is I want you to see here, I asked our residents, pull every paper that is pre-psoas and transpsoas, find every complication on paper that are for real, and see what is the difference. The whole story is this one. Yes, you have more nerve injuries on the transpsoas approach, but when you go pre-psoas, you have more vascular injuries, and you still have nerve injuries. So doing a pre-psoas approach with no monitoring, I think is crazy. You know, it's like trying to land an airplane in the middle of a foggy day with no radar, nothing, just because you're a good thing. So again, don't forget, this thing works by indirect decompression. As long as you have a good restoration of this height and good decompression, it works like a dream. Okay, thanks very much, guys, and happy to answer any question later on. Thank you, Charlie.
Yeah, thanks, Juan. No problem. So as usual, that was a wonderful presentation. Any questions for Dr. Uribe? Yes, go ahead.
What are the negatives to prone lateral? All of this. You mentioned some of the pros. I think that's really not position patient twice.
Yeah, so the question is, what are the negative attributes of a prone lateral transpsoas surgery?
I think that every single surgery, single surgery have problems, potential complications. I don't think that there is a big difference between the position itself still is a lateral transpsoas. So all the same that Juan explained so well, all the topics that he explained in lateral is the same in prone. There are little tips to learn the technique, but it's about the same. You have to pay attention to the plexus. This is key. You have to be oriented, because orientation doing MIS is always super important. We have to be very careful to avoid bowel injuries, and this is not different from lateral. So that's why I still think that, especially in prone, because the patient in prone has more distance between skin to the spine, to the psoas. If you go single incision, your finger will not touch the psoas. It's better that you do like I described on the cadaver. So you do 2 fascial incisions, and you also minimize dissection of the muscle like Juan described, the pseudo herniations. But in essence, there is no much difference between prone, I would say downside. On the other side, we have better lordosis. We have the psoas moving more posterior, so we have more space between plexus and anterior on the prone position. I think prone position is so much natural, allows you to do the procedure 360 without flipping the patient. The only option will be what to do in 5-1. And when you have to reach 5-1, right? In my hands, I prefer ALIF because I pay a lot of attention on lordosis, level per level. ALIF is the best way to reach. But we should build a posterior technique for a 30-degree TLIF in 5-1. That's our goal. Anyway, hope I answered your question.
When would you consider standalone versus like posterior fixation? So what's the indication to do posterior fixation?
Yeah, that's the, kind of, we have that question a lot, and actually Jean and our new fellow, I just told them, let's pull out every standalone case that I'm doing since I moved to the BNI, that was like 4 years ago, and find out in a reverse fashion, what patients are we using it and why and what are the ages. And maybe we can put a paper that can be more helpful, but I can tell you how I function with the standalone, okay? I usually standalone in 2 extremes of the candidate of patients. I use it in patients that the approach has too many problems. Let's say, for example, octogenarians, anticoagulated, COPD, a lot of issues that that even a laminectomy can give us problems, or if they have some deformity and with a laminectomy, this is gonna progress and this patient is gonna live more than 10 years, so you're not really helping them up. So that's a really good candidate for a standalone because there's nothing else that you can offer. And I can tell you, standalone 2-3 levels, they pretty much go the same day. Worst case scenario, they go home next day. So you do it right, it's a 20, 30, 40 cc's blood loss procedure, and these people tolerate it very good, The other good application is young people with discogenic disease that they did everything in life and nothing helping, and they begging you to have a fusion, and you're trying to protect them. At least they don't do a TLIF or something crazy. These young people, you just go in and out, you put a case, they have a really good bone, they have a very low chances of suicide, and that's another good candidate for a standalone. After that, all the spondies, I would say I always use bilateral pedicle screws because the shearing forces, and obviously all the 4 minutes and that, you like to have some posterior support, but that's my ends. I don't know what for you, Dr. Pimenta.
Yeah, for many years, we try to have exclusion criteria for standalones because standalone is such a beautiful, I think is the best fusion technique ever, always, but the problem is subsidence. How then to avoid the subsidence? And so selection on standalone is very, very important. At some point we said, nothing that has instability, degenerative scoliosis, or spondylolisthesis, bad quality of bone. They are the three major exclusions for standalone. In my hands, before moving to prone, to PTP, I would do only in younger males. And right now, even in PTP, we have about 2,000 cases on PTP. There are not many more reasons to do standalone, but right now my answer would be I only do standalone if the patient asks me, please don't make a screw on my back. Then I say, oh, okay, but remember, you may need to come back to the OR. It's not funny. So if you tell the patient that they may need to come back, they will say, oh, no, I don't want to come back to OR.
Yeah, and I think around 10% or less of my lateral cases are standalones. So you can see how is the relation with that. And I basically, you see on the clinics on this month and a half, what we pick, all people with deformity, with a lot of comorbidities or young, and that's basically the biggest candidate. And then you have, as Dr. Pimenta mentioned, you have to do very good doing standalones because what the screws helps you out is to prevent subsidence, because they share the load on the segment. So if you don't use the screws, you're at the mercy of the cages. So you don't want to oversize the cages. You have to go as wide as possible. The end plates are sacred. You have to keep the end plates intact. You have to go from one. You have to deliver a really good procedure. Otherwise, you're just forcing a cage. The patient eventually will fuse, but if you need some indirect decompression, you will not get anything.
Also, interbody versus corpectomy, that also, would you change? Interbody versus corpectomy, that also, you still do like a standalone corpectomy for people?
In corpectomies?
Yes, let's say you do
corpectomies are totally different animals, because you're destabilizing the entire spine, and most of the time you're getting in people that has already an instability. So, if you can accommodate this is a plate that has like a canera type of style, 4 screws, almost bicortical. Good, you can get away without posterior instrumentation, but probably you want to be bulletproof. You just put a lateral and then, put the cage, corpectomy lateral or whatever, and then you put PERC screws and then you get solved, I've seen more and more people doing the corpectomies on prone position, which is interesting. You guys follow LinkedIn on that thing. Sometimes you see that. That's why we say, Pimenta, you have to be careful what you create because then all these monsters come everywhere, and it's crazy. But I would say, as I started at the beginning, you guys need to do laterals. I just can't understand you guys are going to graduate it. You're going to be doing T-leaf, A-leaf, PLEAFs, ACDF. I can tell you, when I was telling my fellows and residents, when I get retired, just like my last 5 years of my practice, this is what I'm going to do. I'm going to move to a VA hospital, and I'm going to do only ACDF and standalones. That's it. That's the best surgery that we do. It's amazing.